Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. So, Tom, welcome to your pharmacology Viva. It's going to be 3 topics, 5 minutes each, total of 15 minutes. I'll stop you when we hit 5 minutes, and I will move you on as able. Are you ready?
As ready as I'll ever be.
Excellent. So, Tom, what agents are you aware of that influence the function of the neuromuscular junction?
Broadly speaking, there are neuromuscular blocking agents or paralytic agents, which are commonly used in anaesthesia, that influence the neuromuscular junction. There are reversal agents, which also have an effect at the neuromuscular junction, either directly or indirectly. And then there are adjunctive medications which can modulate the effects at the neuromuscular junction, such as magnesium, calcium. So, in terms of the neuromuscular blocking agents, these can be divided broadly into 2 classes, depolarizing and non-depolarizing neuromuscular blockers. The non-depolarizing class is significantly larger, and that can be divided into benzoyl and aminosteroid compounds. Now, in the polarizing neuromuscular blockers, we only have suxamethonium. So suxamethonium is presented as clear, colourless solution.
Okay, just holding you there a second. Can you think of any other ways the neuromuscular junction can be affected by agents and any pathological?
Yeah, so we do have drugs similar to neuromuscular reversing agents that act at the neuromuscular junction and can be used in conditions such as myasthenia gravis, such as pyridostigmine and neostigmine. So these act as competitive agonists at the neuromuscular junction to inhibit the effect of competitive antagonists, which we use in neuromuscular blocking.
Okay, excellent. And could you please compare and contrast rocuronium versus suxamethonium for me, please?
For an ideal neuromuscular blocking agent, we would want something that is stable at room temperature, has rapid onset, has reliable neuromuscular blocking effect, and has predictable and preferably fairly quick offset. Now, suxamethonium, and alongside that as well, we want it to have minimal effects outside the neuromuscular junction metabolically and physiologically. So suxamethonium certainly has rapid onset. It's also wears off rapidly within 5 minutes or so. It can cause surges in serum potassium, which can be an unwanted effect. And because it depolarizes, it can have significant side effects. It can cause muscle aches, particularly in younger women, after its use, because of the depolarization at the neuromuscular junction and contraction of the muscles. Comparing to rocuronium, it has a slightly slower and slightly less reliable onset, but still can be rapid if given at high enough doses. It has a fairly low potency, so it can be given at high doses to produce a good concentration gradient to increase the speed of onset. It doesn't depolarize neuromuscular junction, so it doesn't lead to muscle aches, and because it doesn't depolarize the muscle cells, it also doesn't lead to a spike in potassium as you have with suxamethonium. Suxamethonium itself is broken down by plasma cholinesterases, which leads to its rapid degradation and fairly reliable offset. Rocuronium doesn't have such a reliable offset. It is metabolized in the liver and excreted via the kidneys. There seems to be quite a lot of variability in how this affects different patients. So some people, it's a standard induction dose, may have been completely reversed by about 40 minutes or so, but some people can still be significantly paralysed well beyond an hour, even with appropriate dosing.
Sure. So you mentioned the spike in potassium with suxamethonium and myalgia with suxamethonium. Tell me more about the side effect profile of suxamethonium, please.
So, as well as spikes in potassium and possible muscle aches following its administration, it is specifically contraindicated in patients with significant myopathies and people who are 48 hours or greater post having significant burns. This is because of the production of extra junctional nicotinic receptors created in these conditions, which cause greater and potentially dangerous spikes in serum potassium concentration if given to patients 48 hours following burns or patients with significant neuromuscular problems or paralysis. Suxamethonium itself can cause effects on the cardiovascular system, including tachycardia, bradycardia, particularly in children. It has very little effect on the respiratory system beyond paralysing the respiratory muscles, and it has minimal effect on the CNS, although it can cause a transient increase in intra-cranial pressure. In terms of adverse effects rather than just side effects, there is significant rate of anaphylaxis with suxamethonium, but the same is true of rocuronium as well. And rocuronium itself can also cause histamine release, which could be of concern in patients with asthma. Importantly, when giving anyone suxamethonium, we need to be certain that they don't have a history of malignant hypothermia, because along with volatile agents, it is a known trigger for malignant hypothermia and as such can be life-threatening.
Any other side effects at all there, Tom?
All neuromuscular blocking agents, given at sufficient dose, will cause apnea, and that indeed is part of their desired effect. But I mentioned before, there's reliable, quick offset of suxamethonium, but in some patients, they do not have reliable breakdown of the suxamethonium by plasma cholinesterases due to mutations in the gene that transcribes those plasma cholinesterases. These patients can get suxamethonium apnea. There are different levels of severity of this, but it can leave people unable to breathe for hours after administration of suxamethonium, and it's obviously very important to recognise so as to avoid awareness.
Okay, excellent. Now you mentioned malignant hypothermia there. Could you just very quickly talk me through the treatment and management of that?
Once malignant hypothermia has been recognised, it's important to give dantrolene as early as possible. It's important to remove the triggering agents. So if you're using volatile, they need to be replaced with another hypnotic, or the patient awoken if suitable, and their employment of charcoal filter, to remove any remnants, volatile agents from a circle system is also essential, so as to prevent continual triggering of the malignant hypothermia.
And what is the underlying mechanism?
So the underlying mechanism for malignant hypothermia is mutation and dysfunction of the ranitidine receptor in muscle cells that leads to uncontrolled calcium release, and then uncontrolled increased metabolism within muscle cells, which is what produces downstream carbon dioxide, which is one of the things that we can notice clinically when someone is in malignant hypothermia, is a high end tidal CO2.
Okay, so moving on, going back towards rocuronium here, could you describe how you would approach reversing someone who has been paralysed with rocuronium?
So when rocuronium has been used as a paralysing agent, we have a couple of different reversal options. We have Shigamadex and we have neostigmine. Now, Shigamadex is a drug that completely encapsulates rocuronium when it's administered, therefore prevents it having any interaction at the neuromuscular junction and needs complete reversal. You need careful consideration of whether you might want to be using rocuronium again when you give Shigamadex, because it will be rendered ineffective if you need to give subsequent doses. Shigamadex can be given at any depth of paralysis with rocuronium. On the other hand, when giving neostigmine, we need to be aware of the depth of neuromuscular blockade before attempting to reverse. This is traditionally done with muscle twitches and the train of 4 assessment. More up-to-date guidelines recommend the use of quantitative measuring of neuromuscular blockade using train of 4. And based on the depth of blockade, this can tell us whether or not it's safe to reverse using neostigmine, what dose might be appropriate of Shigamadex as well if people are too deeply paralysed to be reversed with neostigmine. Usually glycopyrrolate is co-administered because the neostigmine itself is non-selective muscarinic agonist and can cause bradycardia.
Yes, and what were to happen if you were to administer unopposed neostigmine?
So administering unopposed neostigmine would cause, first of all, the competitive agonism of nicotinic acetylcholine receptors at the neuromuscular junction, which is the desired effect, leading to increased action at the post-junctional membrane and allowing normalised muscle contraction. In addition to this, there can be activation of muscarinic receptors in the parasympathetic nervous system, causing increased parasympathetic tone, bradycardia, vasodilation, and this can have obvious cardiovascular effects such as hypotension and, in extreme cases, asystole.
Lovely. Okay, we'll call it there, I think, on that. I think that's our 15 minutes, Tom.
Righto.
How do you feel that went?
Not that well. So that one felt a bit less structured than previously, and found myself in a similar situation of scrabbling around in my head for what I thought the examiner was after, because obviously it's a big topic. You moved me on quite quickly at the point where I was considering going down the structured approach to each individual drug, but that would have taken too long for what this station was after. So I luckily didn't waste too much time doing that. But also figuring out what depth to go to kind of wrong-footed me a bit, and it felt not particularly fluid and a bit lacking on detail.
The first question was, what agents are you aware of that influence the neuromuscular junction? It's a good idea to try and subcategorize this, because there are agents which block the synthesis of acetylcholine, ones that deplete your stores of acetylcholine, ones that block release, and ones that block action of acetylcholine on your neuromuscular junction. So in the exam, they have a tendency to want more than just the straight up answer of, well, that would be aminosteroids, benzyl lysoquinolineiums, and depolarizing relaxants like SUX. They want you to demonstrate that you know the physiological basis of transmission of a action potential from brain to muscle. You got most of them there in that we covered the blocking drugs, and you mentioned gentamicin and magnesium. But think of Botox, that impairs vesicles actually fusing with and getting out of the neuromuscular junction. Tetanus depletes your stores, but also works higher up to make you spasm. And then very niche, if you gave someone hemicholine, it would mess up the synthesis of acetylcholine. So if you kind of frame it like that, then they'll just immediately be like, okay, he's bad.
Okay. What's hemicholine used for? Just a bit of
It's
learning,
not.
actually.
It's like scientists fiddling around in a lab abusing rats, like stuff.
Okay.
Yeah.
Fine. So in terms of agents that are used, because I think that was the term, was agents, I suppose you don't automatically think of botulinum toxin, but you should, because it is therapeutically used. Yeah. And what else did you mention there? So we talked about magnesium.
Tetanus toxin. So
Tetanus
think
toxin.
about
Is
pathological
tetanus toxin
causes.
used therapeutically?
No. But it's a pathological cause of muscle weakness, isn't it? Like your myasthenias and your LEMS and stuff. I think it's reasonable to think about it from a pharmacological perspective, although it'd be pretty nuts.
Again, it's one you can mention if you don't spend too much time on it. I guess, again, I was thinking of the term agents and trying to use therapeutically. But you need to remember that you don't need to be using them deliberately to affect the neuromuscular junction. It can be side effects, such as often with magnesium and gentamicin. Yeah.
100%. And then we went on to rock versus sucks, and you started telling me about the ideal paralysing agent. And I thought, that might be quite a good structure. But then I think it actually drew you off into the long grass.
And it took too long.
Yeah.
And I had my doubts before I did it, but once you commit it, it's quite hard to backtrack.
Yeah. So I'd be tempted to more go like class, mechanism of action, dose maybe, and then onset, offset, side effects.
Yeah, the more traditional structure for talking about any pharmacological agent. Yeah.
I might not go down the whole route of like, so they are clear, colourless liquids, but I might ask you that later if there's some particular thing I have to find out. And then the other things I wrote was when I asked you about MH, I think you told me all the information about MH, but it seemed a bit jumpy. So if someone asks you a question, define it. So malignant hypothermia is BAM. It presents as BAM. And then I asked you, how would you approach treating it, I think is what I said. So you'd say things like, so if I identify, I would declare the emergency, I would stop the agent, and the treatments I would do are... Because they're also just looking like, do we want you think you're a good registrar, safe registrar sort of realm? And that is parroting that stuff that you're probably more likely to parrot in the clinical question. But if you just say, the definition is this, it presents like that, I'm going to declare the emergency, get additional help, stop the offending agent, and do the treatment algorithm with the quick reference handbook, then it's just like, bam, 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 done.
And it's worth thinking about, I suppose. So again, I think I struggle to frame the question sometimes, and I perhaps overthink it. When you said, how would you treat malignant hypothermia? There's nothing preventing you from giving a quick definition to show that you know what it is. And there may be marks for that. If you get too hung up on the exact wording, go, oh, they just wanted to know about treatment, they didn't want me to talk about what it was. Actually, you can say very quickly what it is, and there may well be marks for it. I think I launched more just into how I would treat it, and that partly affected the structure, which, like you say, it felt a bit here and there and jumping around a bit.
Yeah, it is tricky because you don't want to say too much, but like if someone's asking you a pertinent question about one particular thing, it's worth getting that define or die in and just say what it is. It's a couple of words, and they just be like, oh, of course they know about MH, and now they've started talking about it. And then the last thing to say is I think it's worth just, if you're talking about drugs, just quickly specifying what they are, a bit more like define or die. So you mentioned Sagamodex, but what is Sagamodex? It's a gamma cyclodextrin or something, isn't it?
Yeah, so that was inside my head. I was trying to remember that, and I couldn't, so I just moved.
Yeah. So I think just that casually rolling off your tongue as part of conversation just makes you come across really sharp.
Just to be able to say immediately it's a cyclodextrin, I think will probably be enough. Yeah.
And I mean, just as an aside, I don't know about you, but I think neostigmine is probably the most dangerous drug in the drug cupboard that isn't a paralysing agent. It happened in a trust near me that someone accidentally gave neostigmine as opposed to glyconeostigmine and caused an asystolic arrest because they gave it so quickly. So that's just like a learning point for all, is that neostigmine's dangerous as hell if unopposed.
Especially in these days of affected supply lines, because I know that currently in our trust we do not have pre-mixed glyconeostigmine. We just have neostigmine and glyco separate in the cupboards. So, it's a mistake that could happen.
100%. Well, Tom, thank you very much for accepting the Viva action. Are you going to come back for more?
Yes, always.
Excellent. I like a willing victim.
Yeah, I'm a masochist. But yeah, no, it's good. It gives me some areas to think about and to sharpen up on, because these are all fairly common topics, so probably should be able to give snappy answers.
Yeah, and you will. You'll get sharper, 100%. Practice makes perfect. Thank you very much, Tom. Have a nice evening.
All right, thanks a lot, James. Speak to you next time. Bye.
Ta-ra, bye. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.